Hello everybody. So in this video, we will discuss history taking. History taking requires immense skills. It requires you to have knowledge not just of the disease, but also of people in general. The ability to strike a chord with people, the ability to connect to them, the ability to show sympathy, and the ability to be aware of their needs helps you a lot in this. Now, a lot of this is dependent on non-verbal communication. Your demeanor, your tone, your facial expressions, they say a lot which words cannot. But all this needs a lot of practice. No book can teach you history taking. It's based on practice. History probably is the most important part of patient evaluation. It allows you to evaluate symptoms over a long period of time, like a video. Examination, on the other hand, allows you to evaluate patient at a particular point of time, like a picture. So as you know, a video over a long period of time will give you more information compared to a picture. So if you do not have a diagnosis at the end of history, probably you will not have it at the end of examination also. For example, the diagnosis of asthma is more or less very clear on the basis of history. But when you examine a patient at that particular point of time, there may not be anything. The reason may not be there. So examination in a way helps you confirm the possibilities that you have thought of at the end of history and may help you better define the severity of illness. Begin history taking by evaluating the demographic profile of patient. For this, you have to ask age. In a small child, you will have to ask about date of birth also. You have to ask gender and the residence. Now, there are some diseases which are more prevalent in a particular age group. For example, in children beyond 2 years of age, bronchiolitis will not be a likely possibility. Similarly, some inherited disorders are more common in a particular gender. So gender helps in that way. Some diseases are more common in a particular geography. So residence becomes important in that way. One should always clearly define who the informant is and the reliability. Mother who's involved in the patient care directly is usually the most reliable informant. At times, the mother may seem underconfident or timid in presence of some other relatives, like maybe a dominating mother-in-law or husband. But a more confident and clearer history from father or a mother-in-law who is not directly involved in patient care will not be as reliable as a raw history given by a relatively underconfident mother. So it is very important to involve children themselves, if possible, in history taking. Children at times are able to very well define their illness. Leading questions should not be asked, at least in this part of the examination. In this part of the examination, the patient should be allowed to vent out what they have to explain in their own words. So what is a leading question? A leading question is a question that suggests its own answers. And a question which can be answered in yes and no is a leading question. Let us look at some leading questions. Do you have high-grade fever? Do you have fever daily? Do you have early morning cough? Do you have cough with exertion? So the same questions can be asked in a different way. Do you have high-grade fever? This can be put as, what is the severity of fever that you have? Do you have early morning cough? You can ask at what point of day the cough is more severe. Do you have fever daily? This can be put up as, how frequently do you have fever? Do you have cough with exertion? Now this can be put up as that, what happens to cough with exertion? What happens to cough when the child is crying, laughing? Does it increase, decrease? Does it remain the same? It is not affected by these. So one may ask, how are leading questions going to affect my assessment? So if you ask a lot of leading questions, the patient is likely to change history later on. Have you faced a scenario where a patient gives you another history, but gives another history to the examiner or to a senior consultant? Leading questions have a role to play in this to an extent. But then there is a place for these close-ended questions, when you have to differentiate between the possibilities, when you have to rule out comorbidities, when you have to look for complications, when you have to define the severity of illness. In these questions, you may need to ask closed-ended leading kind of questions. But the place for these questions is later on when you are asking a negative history for these things. Let's have a look at the presenting complaints. The presenting complaints should be presented in a chronological order, which means something which happened first should be presented first and the subsequent symptoms can be added later on. If the child has cough and fever, it is important to know whether the fever appeared first or the cough appeared first. If it was a sudden onset cough, in a child who was apparently well, and later on fever comes up. It could be aspirated foreign body or inhaled foreign body, which later got complicated and the child had pneumonia also. If the child had fever, coryza first, he developed cough later on, probably it will indicate a pneumonia. So if a child has rhinorrhea followed by lower respiratory signs, then probably it was a viral URI, which later on got complicated with a lower respiratory tract infection. If the child has had recurrent episode of an illness, one should consider some points. Now, if these recurrent episodes are likely to be due to one primary illness, then it is better to present it as recurrent episodes of that primary illness. For example, a 10-year-old asthmatic boy who has had recurrent episodes of respiratory distress for the past 3 years, it is better to present it as recurrent episodes of cough and respiratory distress for the past 3 years. Then, in the history of presenting illness, you can start off as the child was apparently well till 3 years back, and then he started having these recurrent episodes. And you can start presenting in a chronological order from the first episode to the current episodes. Now, this will make it easier for the listener to analyze this case. The other way to present it would be you describe the last exacerbation as the presenting illness, that the child had an episode of cough and distress for the past 5 days. And this becomes the presenting illness. Now, the rest of the previous illness can be presented either in the history of presenting illness or in past illness. But this has its limitations. So if you present this as an episode of cough and respiratory distress for the past 5 days, the listener will feel it to be an acute illness, something like a community acquired pneumonia. But later on, when you present this in past history, something else will unfold, and this will affect the flow of history. Now, if you present this as an episode of cough and respiratory distress for the past 5 days, and then you start off with the first episode in the history of presenting illness, again it shows a very abrupt change from presenting illness which was 5 days duration only, and then you have a history of presenting illness which started 3 years back. Moreover, in such a presentation where you present it as a 5 days complaint, there is a lot of negative history that one needs to ask to rule out about for the differentials of asthma and the possibility of asthma, the comorbidities. These negative histories will seem inappropriate if the examiner is not aware that the child has had multiple recurrent episodes for the past 3 years for which the child has presented this time. So now let's discuss the history of presenting illness. So till now what you had presented was presenting complaints. Now let us discuss the history of presenting illness. Present the symptoms in the chronological order. So symptom which appeared first has to be described first, and later on subsequent symptoms are to be added. You can use a graph like this to describe this. So this is a graph that you can use. So this is an hypothetical patient that we are trying to describe. So on this y-axis, you can write about symptoms. On this x-axis, you can write about the timeline. And this is where the child presented to you at this point of time. He had fever. He had episodes of respiratory distress. Then the child had cough. Then probably the child had seizures also. So in this timeline, we can depict this as this is 1 month back, this is 2 months back, this is 3 months back, and this is 4 months back. And the fever started around 4 months back and it has been persisting. The child had episodes of respiratory distress. So the first episode happened at around 4 months of age. The second episode happened at around 3 months of age. The next episode 2.5 months, 2 months. So this timeline shows that the episodes of distress are also becoming more and more frequent over this time. So, and the height can probably indicate the severity of distress. Then you can indicate that at this point of time, probably the child started having cough which has been persisting. Seizures again can be depicted as probably he had a seizure over here, then he had a seizure over here. This point of time, child was started on anti-tubercular therapy. The date can be put up here. At this point of time, maybe some intracranial shunt was put. Again, a date can be inserted. So this graph will give you an overall idea of the chronology of events when you are assessing the history of presenting illness. So if the child has a persistent kind of symptoms, one should present the symptoms in a chronological order, and one should try and define the onset. Now this onset can be acute, it can be subacute. If the onset was sudden, acute, for example, a foreign body aspiration where a child has a history of sudden coughing and choking, and thereafter the symptoms persist. So in this scenario, the parents may be able to tell you the exact date and time of an event which happened months back. So this is an acute illness which started acutely and it has been persisting. And then there could be subacute onset, like in tuberculosis. The patients will come with history of fever, weight loss, decreased appetite for 2 months, 3 months, but they will not be able to tell you the exact time and date. It was something which started as something very low, then gradually increased, and it is progressive and persisting till now. So we have to differentiate between these two types of history when you have a persistent set of complaints. Now, when you have illness which has happened in episodes, one should try to define the duration and the severity of these episodes. And then we have to tell that what is the duration where the child remains well. In this apparent period of wellness, one should clarify whether all the symptoms completely disappear, or is it that the more bothersome symptoms disappear, but the less bothersome symptoms like mild cough, nocturnal cough persists. Also, one should try to find out whether over time these episodes are becoming more and more severe or less severe. Over the time, the episodes are becoming more frequent or less frequent. And one can use a graph like this to describe this. The child had an episode here, then he was well, then he had an episode here, then he was well, then he had an episode of here, and then he was well. So we have to describe how long did this episode last, maybe 3 days, and for how long he remains well. This period is to be defined also, whether he remained well for 1 month or 2 months or whatever. So you have to define this episode also, and the area of the intervening interval of wellness also. Then one needs to ask about aggravating and relieving factors. For example, if a child has recurrent episodes of cough and distress, if the child responds beautifully to salbutamol, it indicates that there is obstruction with reversibility. Diagnosis of asthma seems more likely. The child has more symptoms with dust. These point to a particular diagnosis. Now let us come to that part of history where you have to ask negative history. In this part, we need to differentiate between the various possibilities that are there, to look for comorbidities, to ask regarding complications, to ask to define the severity of illness that has happened in the previous illnesses. For these things, we will have to ask specific pointed questions which can be answered in yes and no. So in this particular region, you can ask closed-ended leading kind of questions, but not in the previous part where the patient is describing his illness. For example, if a child presents with recurrent episodes of respiratory distress, where the diagnosis of asthma seems likely, and the asthma is more severe than what it usually is, one may want to rule out possibilities of allergic bronchopulmonary aspergillosis. So you may have to ask about rusty sputum. And if you wish to rule out possibility of cystic fibrosis, you may have to ask about pancreatic insufficiency. You may have to ask about whether the child is growing well or failing to thrive. Similarly, if the child has presented with recurrent episodes of nasal discharge and the likely possibility is allergic rhinitis, one would want to rule out other differentials like sinusitis by asking about any purulent nasal discharge, any pain, tenderness in the sinus area. Or one may have to rule out a possibility of a nasal foreign body by asking whether the discharge is unilateral or bilateral. Also, if the diagnosis is asthma, one needs to rule out other comorbidities like allergic dermatitis, allergic rhinitis, allergic conjunctivitis. You will have to ask specific leading questions to rule out these. And then you will have to ask a set of questions to define the severity of illness. In a child who has pneumonia, you will have to ask questions to define whether it is a severe or non-severe pneumonia. So you will ask whether the child has lethargy, irritability, cyanosis, general danger signs. That will tell you the child has had severe pneumonia. Similarly, in a child who has had nephrotic syndrome, you will need to ask about pain abdomen, about diarrheas, about scrotal edema to define the severity of that episode. So now let's come to the past history. All these illnesses which are not directly related to the current illness, but they are significant, should be included in this history. They would include things like trauma, any previous surgery, any chronic illness like tuberculosis, rheumatic heart disease, hypertension. All this should be included in this past history. Now, these events which are significant may not seem to be related to the current illness, but they are important and they should be documented. Thank you so much for watching. Thank you for watching this video. Please help us improve the content by commenting in the comment section or emailing at the link given below, especially regarding the length of this video, anything which can be removed or anything which can be added, or any other comment and suggestion. Thank you so much.